Banner is unfurled. Here's a general invitation to the people of the world. Then come along.
Yeah, there. Nice to see that we have at least 25, 26 who are going to be recertified. Oh, not that we're making a big deal about it. Just wait till next month. This is probably a session you could sleep partly through anyway, because it's the perfunctory legal, just like I give you permission this time. It's the legal, the required legal and sort of updating of things. I think it's kind of fun, but then I had a thought of being an attorney once. I had a thought once, and then I stopped thinking about it. So we're going to talk about a number of things, mostly issues of refusal of medical assistance, talking about informed consent, elements of informed consent, talk about a little bit about patient restraint, non-transport, and some things with the Clark County protocols, and also other refusal things, including post forms, documentation of patient care, and some other legal issues. And I'm going to talk a little bit about Pulsera too for the AMR folk. So, informed consent. Informed consent is integral to the concept of informed refusal. Because both are connected. You have to be able to protect the medical decision-making ability of the patient. Now, within the law, a patient has to be informed in order to give consent for a procedure. They also have to be informed in order to refuse any procedures as well, and that includes EMS transport. It's integral to the idea of allowing an information exchange between the patient and the provider so that the patient can make an educated healthcare decision. Historically, in 1982, there was a big ethical commission that was called the Commission for the Study of Ethical Problems in Medicine, and they came up with the firm concept that shared decision-making would be the ideal for the patient professional, the patient-physician relationship, and that informed consent, a sound doctrine of informed consent, would support that shared decision-making thing. Now, it's important to note that prior to 1982, almost all cancer research in the United States was done entirely without informed consent. It was thought that cancer was such a bad thing that, a patient would be happy to have any treatment. And of course, the downsides of most treatment for cancer and things is that you get terribly sick while you're taking the cancer chemotherapy or whatever else it is. There was no proof that any of the cancer chemotherapy was actually going to do anything at that time. So right after World War II, we decided to prosecute the Nazis for things in the Nuremberg trials, and one of the things was experimentation on patients who were prisoners or who were not able to give consent, and this was thought to be kind of a bad idea, particularly because the Nazis did it. If we'd done it, it would have been different. And some of the principles that were enunciated in that were applied then to the idea that a person should be able to make decisions about their own body. Now, this goes back to way back into 1914 Cardozo was a Supreme Court justice, and in a case that he ruled on, he said every human being of adult years and sound mind has a right to determine what should be done with his own body, including medical procedures. 1960, another case, the court decided that physicians are obligated to disclose and explain in simple language the risks and complications of a procedure. Again, in 1972, the patient's right of self-decision is the measure of the physician's duty to reveal. Now, that's a oddly constructed sentence, but it basically says the physician has to, a good physician would give the patient all the information they need to make a self-decision. Now, now what if the patient is unable to make an informed decision and they refuse care or transport or treatment? So, refusal of care starts to deal with the idea of competency versus capacity. Competency is a legal test. Three-step legal test. A judge in a court of law determines it. Can the individual retain and comprehend relevant information? Can the individual believe that information? If he's a total paranoid schizophrenic, he's not going to believe anything that a person of authority tells him. Can that individual use the information that he's given, him or her, to make a choice? That's a three-step legal process, and we can't do that in the field. We can't do that in the emergency department. We can't do that in the hospital. So we have to deal with an alternative, which is capacity, which we can establish. It's a presumptive determinant of competence. If a patient refuses and evidence exists indicating that that patient is impaired in their capacity, it's appropriate to conclude that that patient would probably be found incompetent in a court of law. It's not 100%. An impairment can be determined by what the patient does in front of you or information from caregivers, relatives, etc. So in the case of an Alzheimer patient, if they say, he every night at sundown he wanders away and disappears into the wood and he gets lost, that's evidence that he's probably not of capacity. To establish capacity, does the patient understand the nature of his medical condition, his or her, and the potential consequences of refusing treatment or transport? You can assess capacity noting that they don't have deficits in cognition, what they're able to understand, to see and interpret, judgment, how they can assess their own situation in regards to what's reality, their understanding of the situation, the medical condition, the problem, choice, that they're not being coerced into making this by you, by a caregiver, by someone else, by the police particularly, and that they have an expression of choice, that they're able to say, yes, I want to do this or I don't want to do this. Some people don't feel like they can express their own choice. And stability, if they're laughing one moment, crying one moment, screaming at you one moment, it's probably not very stable. So, decision-making capacity, They can't have deficits in any of those things. What you have to realize is that their decision-making capacity, their ability to make decisions, is the thing we scrutinize, not their ultimate decision regarding their health care. You may totally disagree with their decision, but that doesn't mean they're not of capacity. If you think they have capacity, then the patient's wishes regarding their own health care must be honored. Disagreement with you doesn't constitute lack of capacity. Now, in this case, Lane versus Kandura, the court ruled supporting that the patient had the right to determine treatment even despite the physician's advice, and that even if it was irrational, it seemed irrational to the physician and maybe even to the court, that did not justify a conclusion that he was incompetent. He just didn't want to do what the physician wanted. Now, elements of informed consent are autonomous decision. The patient has to be able to make a decision on his or her own. C, a capable individual, so someone of capacitance, someone whose capacity is not impaired in any way. Disclosure of adequate information by the provider. You have to give them, you can't lie to them, and you have to give them enough information. And then comprehension of the information by the individual. How do we check comprehension? We usually ask them to repeat it back to you, or say, what do you understand I just told you? And if they don't speak English, that's a problem. And if they're deaf and you didn't have a signer, that's a problem. You can't tell that they've got comprehension. The more serious the patient's potential problem, the more stringent the standard of comprehension is required. So if it's a whole different thing, if somebody has a minor laceration, it's not bleeding, just a minor laceration, you say, well, you should go in and have this sutured. Could get infected. They say, okay, I don't really want to. Do you understand that? Yes. And they say, well, okay, I'm not going to go in. Okay, that's not as big a deal as we think you're having a heart attack and you could likely die if you don't get treatment or be seriously impaired. That's a lot bigger deal. And so they have to, if they're saying, well, I don't believe you, I'm not going to do this, I'm going to go, think about it for a while. You get to question capacity a little bit more at that point. We usually consider refusal of transport, particularly if you want the patient to go to the hospital, as refusal is a high-risk issue. Our typical matrix, A, B, C, D, patient desires transport on the lower one, EMS desires to transport, yes or no, patient desires transport, yes or no. If both agree yes, transport, then that's not a question. We never have a problem with that. B, if you think the patient needs to be transported and the patient says no, that's a refusal. If you don't think the patient has to go to the hospital and the patient doesn't want to go to the hospital, that's no transport. But if you don't want to transport the patient and the patient really wants to go, that's a denial of aid. Now that could be a problem. It is a problem, and we'll talk about that a little bit more. So, true refusal of medical assistance. When the patient refuses, EMS disagrees, you think the patient has to go to the hospital. Key issue there is you need to advise the need for treatment, transport. Patient refuses despite understanding the risks. This is a documentation issue then. If the patient wishes to be transported and you don't agree, it's generally speaking impossible to justify failure to treat or transport if the patient has an adverse outcome. Almost all cases where EMS gets sued involves leaving a patient at home when they call for a medical problem. Now, we have a couple of special cases that we deal with on an individual basis that I have to talk about, and those are the cases, the exceptionally loyal customers who call you and get transported 50, 60, 100 times a year, never get admitted to the hospital, are clearly psychosocial issues, and on an individual case-by-case basis, we will develop a no transport policy. But ordinarily, when a patient calls you because they're having, quote, and of course these people learn how to get around, because if someone calls with chest pain, we evaluate and generally transport the patient, even though the 12 lead is normal, all the vitals are normal, because the downside of missing, there's a big liability thing if you just leave the patient. Almost all suits that I'm aware of that have been lost by EMS have to do with leaving a patient at home. Now, you don't have to be totally anxious about that as long as we follow the basic rules. And the basic rule will be individual by individual basis, we'll deal with this. Now, what if the patient doesn't want to be transported and you agree? There's really no medical need. So here's an example. Motor vehicle accident. Patient didn't call. It was a drive-by call to 911. There's an accident. Patient's up walking around kicking the tires. You get up, and he says, I'm fine. I don't have any injury. And if you both agree on that, okay. Now, if you initiate patient care, taking vitals, providing a diagnosis, reassuring the patient's fine, oh, you don't really have anything wrong with you, then you have to, if the patient isn't going to be transported, that's a refusal, and that has to be documented explicitly. But if you get there and there's no patient, because the patient says, oh, I'm not a patient, I didn't call, it's okay. Now, what are the problems if you restrain a patient? You think, well, the patient's not of capacity, I'm going to restrain them physically or chemically while we transport them. Well, you could be charged, the patient could say, well, this was false imprisonment, which is restraint without justification or authority, which is why you document in your medical incident report what you found and what you saw. And you document that you made a phone call to medical control. So it's an intentional and unjustifiable detention of an individual without consent. So they would have to prove or allege against you that you had an unjustifiable detention of them. What about assault or battery? Assault is unlawfully placing an individual in apprehension of immediate bodily harm without their consent. So that's jumping on a patient, holding him down without trying to talk them into, without telling them what you're doing, basically. Battery is unlawfully touching an individual without consent. Have we ever been sued for assault and battery in this county? No. So, as long as you follow the basic rules of engagement, which are you attempt to reason with the patient, attempt to determine their capacity, attempt to determine if they can participate in your thing. And of course, the biggest ones are psychiatric patients. We have the problem with psychiatric and intoxicated. Then you go through the stepwise process, but then you document. Abandonment, a premature termination of the physician/paramedic-patient relationship. Failure to follow the necessary steps to ensure definitive care. And abandonment includes having an ALS patient and giving it to a BLS person, except in the cases when you're in unusual circumstance, such as mass casualty. So if you decide you don't like the guy because he's argumentative and nasty, and you have and he may or may not be having a real medical, and you let your EMT partner ride in with him and be in the back and take care of him, and an adverse event occurs, that's called abandonment. And that's hard to argue in court. Reasonable force, we've talked a lot about that, dealing with the police and how they can do reasonable force. They're quite anxious about it because their reasonable force sometimes escalates to lethal force. Reasonable force is the amount of force required to ensure the patient doesn't cause injury to himself or others. Excessive force is something you decide after the fact generally, but excessive force could put us in EMS liability. Now, this is why we don't use handcuffs in paramedicine. It's not, that's excessive force. Soft restraints, chemical restraints with medical control concurrence. All right, what if you're not going to transport a patient? Well, general guidelines. Reasons for non-transport: assigned refusal for transport, or no patient for all sorts of reasons. Code 99, termination, death in the field, no patient found at scene, etc. Now, patients refusing care and transport, they could be of no medical need, or they have normal decision-making capacity and they decline after being informed, or they have an impaired decision-making capacity. And sometimes those will not end up being transported despite our best effort. Impaired decision-making capacity, they cannot understand the nature of their illness or injury, or inability to understand the risks or consequences of refusing. Some of the causes of impaired decision-making capacity: alcohol, drugs, psychiatric conditions, injuries, including head injury, shock, concussion, Alzheimer's disease, mental handicaps. Minors under 18 years of age are generally considered not able to make decision. They have a, quote, impaired decision-making capacity legally. Language communication barrier, including deafness. Criteria for informed consent. Patient criteria for informed consent. The patient has to be given complete and accurate information about the risks of refusal and benefit of treatment. Now, we make it the complete information. Let's say someone's having a STEMI, you think they're having a STEMI, and they refuse. Well, your complete, accurate information might include, you could die, you could have significant cardiac impairment, a markedly reduced ejection fraction, and be chronically congestive heart failure all your life until you die of heart failure. You could have a stroke. Could have a number of things. All you have to do is tell them the first couple things. You could die or be terribly physically impaired. That's enough. You can't give them every single possible thing to be complete and accurate. So give them the worst, which is what we settle on. If they refuse knowing they could die or be in a vegetative state, that probably is significant enough. If they can't understand that, they're not going to understand that the rejection fraction is going to be reduced. So the patient has to be able to understand what you just told them and to communicate that back to you. So we asked them to paraphrase it. What did you understand? What did you understand I just told you? And then they have to make a decision consistent with their beliefs and life goals. And now that's the kind of tricky one, because that gets into what seems to be maybe to us rational or irrational. A person who's been a lifelong Christian Scientist could say, well, thank you, I didn't, my wife called because I was complaining of chest pain, I understand that you think that I'm having a heart attack. I've been a lifelong Christian Scientist, and I'm going to go to the reading room and spend some time meditating and praying. You may think that's crazy and not rational, but that's consistent with life goals and beliefs. Okay, so if the patient is capable of making medical decisions and there's no medical need, a refusal form is, strictly speaking, not necessary. So this is the case of the person walking around kicking the tires at the scene of the wreck. Just document the events necessitating the call, the criteria for no patient, no medical need. Now, if there's minor medical need, if they have a minor problem, and they're capable of making a decision, still have to have a refusal form. Documentation is your normal documentation: chief complaint, events prior and reason for the call, pertinent medical history, description of scene, etc., etc. Physical exam, treatment provided, instructions provided for patient family, RE risks and benefits of treatment. So, case you might have a little kid who fell off of a swing. It's probably broken his wrist. The mom or dad says, we're going to transport him to the hospital ourselves. Minor medical need. You haven't sedated the child. You haven't given them any medication. If you give them pain medication, they then become a transport. But minor medical need or a minor laceration, they can sign a refusal. But you have to do risks and benefits. Now, if they have immediate care or transport needed and they're capable of making a decision and they're refusing transport, then absolutely you need a refusal form. And you do everything you can to convince the patient to receive care, which means assistance from family, law enforcement, if not, mental health professional, clergy, etc. And mandatory consult with medical control is necessary. Explain the refusal form, instructions and liability to the patient, signature of patient witness, etc. They can still refuse, particularly if they're of capacity. Now, if they're not capable, if they're not of capacity and medical transport is necessary, once again, every effort to convince the patient to accept care, consider restraint and chemical both chemical and physical at that point. Consult with medical control is mandatory. These are probably psychiatric patients or head injured patients, people who, now, head injury at the scene of an accident is a little bit easier because usually they're significantly impaired enough you're going to be, it's not a question of their signing a refusal or wanting to go with you. You'll end up doing what you need to do to take care of them. But consult with medical control is mandatory for patients refusing care who, or attempting to refuse care, who are not capable. So, when you contact medical control and then you say, I think we need to restrain this patient, and they will concur or not concur based on what you tell them. If there's no way that you get the patient to comply, then they would have to have a refusal form. And it has to be the same refusal form that we always do: instruction, release of liability of the patient, signature of patient, legal guardian, signature of witness, and extreme documentation. Now, we have changed the patient refusing care county refusal form slightly. We're going to go through the highlights of it. It will probably look almost like it used to, but we've got some differences. First one, determine capacity. Clearly document your assessment, why you think that the patient is not of capacity or of capacity. Your assessment in your EPCR. We have taken the assessment evaluation out of the refusal form. There used to be a section on that where you would outline, and a copy of this would be left with the patient. We've taken that out because it's duplicative, and people, when you fill out two forms on the same patient, there could be omissions from one or the other. And we only want one set of documentation, because I don't want to leave a piece of paper with the patient that says, your 12 lead was normal, and the 12 lead documentation in the EPCR says it's clearly a STEMI. That would not be a good thing. So we don't want to have two pieces of paper that could be used in court as counter arguments. So all your documentation will be in the EPCR, and that will stay in the EPCR. Then, when you contact medical control, document the MD, orders given, other pertinent dialogue with that physician, indicate any instructions to the patient via medical control. If medical control is not contacted, document the reason in the MIR. They didn't answer the phone. We couldn't get through. Whatever. That's probably not a good argument. If you decided not to call, I want to know why. So that's in our format now. Document your advice to the patient. Treatment and evaluation needed. Further harm could result without this treatment, and transport is needed. That's clear. Check boxes. Simple. Indicate the disposition. They refused all EMS services, refused treatment or transport. Now, sometimes we end up with patient diabetic who wakes up after getting D10 and is perfectly cogent. Their glucose is now in the 120 range. They're eating, they're talking. They say, I forgot, I'm not going to go in. I'm not on oral hypoglycemics. They can refuse. You need to document all that. document refusal of EMS services or refuse treatment or transport, document if they're in custody in the agency and officer, in care of a relative or friend, document name and relationship. Explain the remainder of the form to the patient. The patient signs and dates release of liability. The rest of the form has all the stuff. It's pretty much exactly the same as it used to be. Documents that evaluation treatment has been offered to you. EMS treatment can't replace evaluation and treatment by a doctor. Encourage transport. Condition may not seem as bad as it actually is, and you could have more problems on and on. Don't wait if you get worse again, call 911. Checkbox if your condition and problems have been discussed with the doctor at the hospital, medical control, and then they sign, I do not wish treatment and transport. I accept full responsibility, etc. So the form is a little simpler, a little cleaner. It doesn't set us up for arguing forms. Now, the state post form has changed a bit. Still pretty much the same, but it's morphed away a little bit from a form that was mostly for EMS to a form that seems to be useful for hospice, useful for physicians, and less useful for EMS, which is kind of an interesting thing. Do not resuscitate. Do not resuscitate order is a physician order basically to skilled nurses. Strictly speaking, a DNR order is only valid when the patient is in the hands of a skilled nursing personnel. So hospitals, skilled nursing facilities. Problem with skilled nursing facilities is that you can still be a skilled nursing facility and have an LPN on at nighttime. LPNs are not considered skilled. It's an RN as a skilled nurse. And they use DNR orders inappropriately in some other situations. They try to use it in non-skilled nursing facilities. Strictly speaking, though, there's a lot of adult foster homes, and they do not have skilled nurses, and they cannot have a DNR order. So you should really never be called to a place that has a DNR order. I intentionally said that as a bad joke, because you should never be called to a skilled nursing facility on a patient who has a DNR order, because that should be the first thing in the patient chart. But you know how it works. So, because in the event that the patient has a cardiopulmonary arrest, CPR is not to be administered. Okay. Well, then we get living wills. Living will is a legally executed document, which means that you generally have to have, well, you don't need an attorney to put it together to do a living will, because the states, both Washington, Oregon, and California, have examples of living wills that you can download from their websites and fill it out yourself and do that. And at the very beginning of every state's thing, it says, we suggest that you have an attorney do this. It's a legally executed document expressing the oral and written instructions about medical care for patients when they're unable to express their medical wishes, i.e. when they have a stroke and they can't speak, i.e. when they have a cardiac arrest and they can't speak and they can't direct their own medical care. Also known as an advance directive, it provides end-of-life directive. Now, they're a large form. The one that my wife and I have has, I think it's 38 pages long. By the time you get done reading it, I'm going to be dead. That's okay. Yeah, that could be the goal. But I mean, they're total. They cover everything, including giving directives, identifying someone who could be a surrogate for healthcare decisions. So it's a very complicated form. And it's the best thing to have, but it doesn't work really well in an emergency. If you really need to make a decision quickly, you have to scan through 38 pages. Now, if you have DNR orders, if you have a living will, and also a pulse form, and still you get called on an apparent cardiac arrest, and the friends, nursing home, family, whoever says, oh, the patient's not to be resuscitated, then why did they call you? You follow BLS protocols while you attempt to determine if there's a written pulse form, a DNR, or a living will. Continue BLS. In the absence of those forms, you call medical control, or if you know the attending physician, if you're, if they're available. And then you have to document, if they have a pulse form, a DNR, or a living will, document that in your patient care report. No BLS or ALS procedures should be performed on a patient who is the subject of a confirmed pulse DNR or has a living will and is pulseless and non-breathing. Now, what about pulse forms? Pulse form, I look at it as a way of translating advance directive into physician orders. Here's the deal. State of Washington, state of Oregon for that matter, when 911 is triggered, you have a duty to treat. A duty to treat can only be relieved by a physician order. The pulse form allows a physician order to occur before the event, so that although you have a duty to treat, and when you find somebody in a cardiac arrest, your duty normally is to go ahead and do everything you can for that cardiac arrest until relieved by the physician order. You already have a physician order when you have a pulse form. The only other physicians who can relieve you, if there's a physician at the scene, or a nurse practitioner, or a PA, they will also work. But they have to be at the scene. They can't call in. The only physician who can relieve you over the phone is me or my designated medical control officers. We give you orders to stop. That's why when you're doing a full code 99, I still want you to call in to medical control and say, now you don't have to call in if there's a pulse form. Call in when you are unable to resuscitate the patient and say, I'm going to terminate. I think we should terminate this event. And then you're given permission by medical control or not, occasionally. The POLST form summarizes that, so it's an advance directive in simple form with a physician order attached to it. The advance directive doesn't have a physician order attached to it, really. Has an attorney's name attached to it usually, and that doesn't work. It summarizes the individual wish for the end-of-life treatment. It is not an advance directive. It doesn't really replace it, but it summarizes it, makes it simple, because it works in an emergency. So Part A applies only if the patient's pulse is synaptic, and it says very simply, attempt resuscitation of CPR or do not attempt resuscitation. So if they're not in cardiopulmonary arrest, you go to Part B. Part B has now changed. It's the new form. It didn't make much sense to start, the original one was start out comfort treatment only, selective treatment, and then full treatment. It was just the reverse of this. It only makes sense. You don't sort of go through, you either decide to do full treatment or nothing. I said, we made this change ourselves. We said, EMS is going to either, they want to know if you want to do full treatment right off the bat or less than that. You don't want to start out with comfort treatment and then move on to selective treatment and then move on to full treatment. So we reversed that and made it better. And full treatment includes transfer to the hospital if indicated. So intubate, airway, mechanical ventilation. So it's very straightforward. Selective treatment may be transferred to the hospital if indicated, but in the hospital, we said, don't put them in the intensive care unit. If they want full treatment, we'll put them in intensive care. And comfort treatment is pain relief only, oxygen suctioning as needed for comfort, etc. And they would prefer, the patient would prefer no hospital transfer, but EMS contact with medical control if you can't provide adequate comfort at home, that you still may end up transporting. These are the signatures necessary. It needs to be signed by the patient, it needs to be signed by the physician or nurse practitioner or PA. This is non-emergency medical treatment preferences, and this is had been advanced a little bit. We don't give antibiotics, but that's a good. We end up taking a lot more sepsis patients to the hospital now than we do STEMIs. And the pulse form will come in real, because a lot of these septic patients may have a pulse form and they don't want antibiotic treatment into life. I mean, except for symptom management. It tells you whether they want medically assisted nutrition. Doesn't count as an IV. You still start IVs if they want full treatment or not. And gives just additional orders. So it's a lot more. The Part C and Part D are not as applicable to us. So, yeah. I'm sorry? Yeah, they'll still, because they may still get fluid and stuff. It's not a, the problem is you probably won't find pulse forms on most of these old septic patients you bring in from nursing home with their urinary tract infection gone bad or pneumonia. They won't have a pulse form. But I would still take them in. If you're going to be transporting them anyway, I would take them in. The decision really resides at the nursing home if they would be transporting them. Any incomplete section of the POLST form implies full treatment for that section. So if they haven't checked the boxes in that section, it's still valid. It's valid in all care settings, including hospitals, until it's replaced by a new physician order or a new POLST. It's a set of medical orders. The most recent POLST replaces previous POLST or any previous orders. POLST doesn't replace the advance directive. POLST should be reviewed by the physicians to make sure that they're, every time you go to the hospital, you either continue taking that same POLST or you get a new one. Whoop, going back there. Don't put a defibrillator on a person who's chosen do not attempt resuscitation. When comfort cannot be achieved in the current setting, a person should be transported to a setting able to provide that. So if they fall out of bed at the nursing home and break their hip, even though they have a POLST form, even though you can provide them temporary relief, maybe with a little fentanyl, you're unlikely to keep that patient's going to be transported to the hospital, even though they said ordinarily for comfort care only, I don't want to be transported to the hospital, but they're not going to get complete relief of their hip pain in the nursing home. An IV medication to enhance comfort may be appropriate for a person who's chosen comfort-focused treatment. So, IV fentanyl may be appropriate. Treatment of dehydration is a measure which may prolong life, so a person who desires IV fluids should put down selective or full treatment. Oral fluids and nutrition are always offered if medically possible. Usually POLSTs are considered for people with serious injuries or frailty. Frailty is a hard thing. I know people who have POLSTs who are simply 80 years old and want to have them now. It should be updated frequently. If you live to be 95, you should probably update it every year. Has to be signed by the physician, ARNP, PA. Where do you keep it? Well, the usual thing, fridge, bedside, back of door, with meds. In the healthcare setting, it should be kept in the chart, kept during transport. It should be the first thing in the chart. POLST is a set of medical orders. The POLST can be revoked by the patient verbally. I mean, how many times have you had a POLST or a don't intubate order and the patient who's short of breath says, I'd like you to help me breathe? They can revoke it at any time. You can revoke it by ripping the form up or chewing it or whatever you want to do to it. You know, my dog ate my POLST. Physician, he revoked my POLST. A physician can revoke it. Said, oh, the patient really didn't want this. A legal surrogate identified in the advance directive can revoke it. So, we provide resuscitation based on the patient's wishes, provide medical intervention identified on the form, always provide comfort care. When in doubt, contact medical control. Comfort care measures are medication by any route, positioning, wound care, other measures. Oxygen, oral suctioning, manual treatment of airway obstruction is needed for comfort. What about airways? No invasive airways, and that includes an eye gel. If they'd said no resuscitation or no full treatment. Document your MIR, indicate DNR by post, patient's physician, why you were activated, document contact with medical control, patient's own physician, medical examiner, law enforcement, the usual kind of stuff. Now, Oregon has gone way beyond Washington in that they have an electronic pulse registry, which allows EMS access to pulse even if you can't find it. There's a unique identifier assigned to each patient. If you don't know that identifier, that's okay. Call, and generally within 1 minute, they can find the registry and confirm with you whether this is a genuine pulse form or not, a valid pulse form. And now that, of course, only works if the patient is registered with the Oregon Pulse Registry. So a lot of, I'd say roughly a third of, maybe a quarter of the county has physicians in Oregon, that includes Kaiser, and they may be registered with Pulse. Not usually their family knows, oh, he sees his doctor in Portland and he has a pulse form. I can't find it. Call that number and within a minute they can find you the documentation. Okay, sometimes, even though the patient has said what they want to have happen if they're a code situation. Sure. We've got it written down. It's in your orders too. 503-418-4083. We should always respect what the patient wants as far as resuscitation goes, but the family sometimes, as you know, vigorously insists on CPR. Do everything you can, even if you've got a directive. Continue treatment, continue your continue on with ALS treatment as demanded by the family. Don't get into a fight over that, and contact medical control. Generally speaking, most patients, even though we're getting better and better at it, you're not going to get ROSC on well, we get ROSC now on about 60% of our codes. So you do have the chance of moving on to resuscitating someone who didn't request being resuscitated. The difficulty becomes, you don't want to get into a fight with the family over that at that point. I don't think we've ever been sued for wrongful life. So, that is a problem. Sometimes it works to hook the family up with medical control. Sometimes that doesn't work, and you just do the best you can. Okay, let's take a break for about 10 minutes. Got any questions on that up to this? Okay. Well, let's get going again. Let's circle the wagons again here. Okay, 4, documentation of patient care. A state of Washington approved EMS, MIR, or other approved electronic report format must be appropriately documented and filled for any call for EMS assistance resulting in patient contact within Clark County, regardless of patient transport. Applies to all responding agencies, includes public assist calls. Certified EMS provider in charge of patient care must provide the following information to the receiving facility staff. A brief report on arriving, including date and time, vital signs, serial vital signs where applicable, patient assessment findings, procedures and therapies provided, changes in patient condition, and mechanism of injury or type of illness. Within 24 hours of arrival, a complete written or electronic patient care report that includes, at a minimum, names and certification levels, date and time, age of patient, components of system response time is defined, you know, all the stuff that comes out of dispatch. It's all part of your MIR report. Vital signs, assessment findings, procedures, patient response, mechanism of injury, type of illness, patient destination. That's within 24 hours, a complete written or electronic patient care report. What is patient contact? It occurs when a provider contacts, sees, hears a patient, even if other providers are unseen. That's why when you have both fire and AMR at the scene, both are involved. Treatments and evaluation provided while said providers in contact with the patient shall be documented. EMT and paramedic provides health care. Yep.
A few slides ago, you said that you wanted to minimize the refusal form because there was redundancy, but
Yep.
you want us to include patient share?
That's not, and your two patient reports should be complementary and not conflicting. What the problem with the documentation, with the redundant documentation in the patient refusal form is that, first of all, that's in the same, your MIR may not match what you write down in your patient refusal form, because I'm recognizing that we're only too human. We don't, you know, you can't go step by step by step always the same. So I don't want to have two forms in the same chart, because you will have a copy of the refusal form in your chart. I don't want to have two forms that don't match. That's what the redundancy there. The redundancy of having fire put down what they see in their, and is going on in their presence, it should be the same. It should be complementary rather than redundant. Healthcare is the participation in evaluation and decision-making process, which includes interview of patient, family bystanders, treatment of the patient with procedure and medication, even if other agencies are on the scene and also involved in patient care. That's why you both write down things. And generally speaking, one agency precedes the other. Patient care report is a legal document. Should reflect the incident as accurately as possible, completed as soon as feasible after the patient encounter. All reports completed prior to the end of shift. Now, if your shift is 24 hours, you get a little bit of a break on that one. If your shift is 8 hours or 10 hours, it's completed at the end of your shift. If you wait till the next day or the next time you come on, you always screw it up. Or something bad happens in between that time period. You forget things. I had the same problem with physicians. I did not allow physicians to take charts home, did not allow physicians to not get their paperwork done at the scene because they forget. You don't document stuff. Or worst comes to worst, because the business we're in, a patient who had a trip, had evaluation, was maybe reasonably refused transport, then before you get a chance to fill out the form, the patient has another event, same thing, and then, gosh, the wife doesn't remember that he signed the refusal form. It wasn't told that he might be having a heart attack. So we don't want to repeat those things. So you get them done before the end of shift. Transporting units leave a complete report or a field worksheet at the receiving facility. Transport agents are required to provide a complete MIR to the receiving facility within 24 hours. If you use a written format, we use the SOAP charting, but almost nobody in this county does that anymore. You use an electronic form. It's a legal, SOAP is subjective, objective assessment and plan. It's a 50-year-old system of documentation, so it's perfectly okay to use the electronic formats. And we've approved all documentation guidelines for each particular thing. ESO has a little bit different documentation guideline than does AMR's form, does Firehouse has a different thing too.
How do electronic formats stand up in court?
Well, everybody uses them now, so you know, and you know, Epic is, you know, literally for hospitals and emergency department, Epic is the charting format that is used by 96% of all the hospitals in the United States now. And well, you know, seems to stand up as well as anything. And I agree, you know, electronic format, it has its downsides because you can check a box or fill a thing out electronically, and you know, in court they'll ask you, did you really do this? And you said, well, if I filled the box out, I did it. Well, that's not necessarily true, is it? But they seem to, you know, that it seems to be, it doesn't seem to be any more risk than we used to have. And probably because both systems have, you know, when you're doing a SOAP format, it's limited to how anal compulsive you are as in filling out all the things. And I had a physician at Southwest that literally looked at, I could look at their charting and I could substitute I could substitute any name of any patient into the thing because all of the dictated SOAP charts were exactly alike. As if there was any difference in the person, you know.
It seems like it's electronic format only would contradict the statement if it's not written, it wasn't.
Well, it could. That's why the electronic, in all of your electronic formats, there's a section for free text that's called the narrative, and we find a lot of stuff in the narrative, and when we're reviewing charts now using ESO or using AMR's format, because we've got a electronic screening device now that calls out, you know, we look for elements in the chart. We will find, you know, like in a STEMI, for example, that it'll say, well, they didn't give aspirin, or there's no documentation of allergy to aspirin. Well, we look in the narrative and we find that, well, not only did the patient take the aspirin before they arrived, but it was perfectly documented in that, or the allergy was documented. So, you know, that's why we have to look at both things. So a good format will have both. Because you're correct, if it's just an electronic checkbox, you can miss things. Okay, level of care during transport. Attendance of the patient during transport will be appropriate to the degree of illness as determined by the paramedic. You are in charge. All ALS transports will be attended by an emergency medical technician certified by DOH to provide appropriate ALS procedures. The only exception may occur during mass casualty incidents. Recently, I had a little counseling session with a medic who had their EMT draw up and give a medication, specifically epinephrine, as a teaching, as a learning experience. And we do, of course, allow EMTs to draw up and give epinephrine rather than use an EpiPen because of the expense and all that, but we have a training program for them to go through that. It's not an on-the-job training program. It turned out that the person gave a full milligram of epinephrine. It was a healthy enough person that made no particular problem with that, but this became a learning episode for both personnel, and this is not allowed under state law. At least in that format, the person has to be trained and they have to go through a process, and then of course there wouldn't have been an issue of getting a milligram of epinephrine. Inappropriate assignment of medical attendants is grounds for suspension of standing orders for both persons. Now, we use this as a learning tool. Other illegal issues: disciplinary process, grounds for denial, revocation, or suspension of an EMT certificate, including paramedic certificate. Misrepresentation in obtaining the certificate. We generally expect that most of you who get a certificate actually went to paramedic school. Engaged or attempted to engage in activities outside the scope of the certificate, including misrepresenting oneself as being able to perform outside the scope. You have to understand your scope of practice as an EMT, your scope of practice as a paramedic. Demonstrated incompetence, violated or aided or abetted in violation of RCW 1873, which is basically falsification of records. Either the MIR or other personnel records. Violation of patient care protocols. Failing to maintain skills. Repeated failure to follow protocol or patient confidentiality rules. Use of alcohol or controlled substances affecting your ability to render care. Represent qualification at a level other than your certification level. So if you're an EMT intermediate and you maintain that you can do what a paramedic can do and you do paramedic-based things, you are then misrepresenting yourself. Alteration of a DOH document or possession of an altered document. So alteration of your certification. Violation of probation if you're on probation. Cheating on or assisting another to cheat on a certification exam. That used to be a big one back when the state had their own certification exams for particularly EMTs, because people were always selling or trading copies of the test. Assisting another to obtain certification via fraud, forgery, misrepresentation, deception, or subterfuge. Illegal distribution, administration, or dispensing of a controlled substance. Means you can't take the fentanyl home and sell it to your friends. You just have to take it right there at work. Yeah. Conviction of gross misdemeanor that affects one's ability to function. Falsification of patient records, failure to provide true information regarding certification, recertification, demonstration of incompetence, conviction of a felony, failure to complete CME requirements or MPD remediation. violation of rule, regulation that jeopardizes health or safety of the patient, performing medical procedure not approved by the MPD or approved training. Now, sometimes that's not your fault. Sometimes that's the problem of the MPD. We have to occasionally correct an MPD who gives you an order to do something that's not within the scope of practice. So there's a bunch of ways you get in trouble, but the worst way is lying about something, falsifying a patient record. As a general rule, most of us MPDs look at violations of protocol as learning events, teaching events. Blood draws, other legal, blood draws for impaired driver. Just a refresher on this. Blood for legal alcohol, marijuana, or other drug determination may be drawn at the request of law enforcement. When the officer has reasonable grounds to believe the person's in violation of the RCW that says driving or being in actual physical control of a motor vehicle while under the influence of intoxicating liquor and or drugs, including marijuana. The officer can request blood drawn either due pursuant to a search warrant. That's the best way, and they can do that after the fact. You don't have to be, and so now we've set up with most of the police agencies, we've set up they can go to actually to the fire station or to AMR, or have AMR come to them and have blood drawn by a search warrant. That requires a judge to issue a search warrant. So that'll occur after the event. A valid waiver of the warrant, now they are asking the patient to, now this is kind of an interesting about patient consent, because there's a subtle coercion here, but I understand it. And the coercion is, if you don't agree to have them draw your blood, you automatically lose your license and you're charged with a DUI anyway. Well, if I agree, am I giving my voluntary consent? That seems coercion to me, but that's the way the law is written.
Do they have to have them sign something?
Yes, yes, they have to sign a consent form. What? No, because that doesn't, this brings up an interesting thing which kind of relates to the consent forms we talked about, is that if they're intoxicated, blood or legal breath alcohol, blood alcohol is 0.08 in this state, unless you're a minor, and then any amount of alcohol is a DUI. However, that doesn't really imply capacity. And they will argue that, well, no, it impairs your ability to drive, but it doesn't impair your capacity to make a medical decision or to make a decision to allow to consent. And you say, well, how can that be? Well, because what is the legal limit of inability to have capacity? It depends, the detox center won't take you if you have a blood alcohol of more than 0.35, or if you blow 35 or better. And that's a fair amount. That's a fair amount of alcohol, really. But you've seen people out there that are chronic alcoholics. They actually have, that's kind of their normal state, and they kind of are at sort of normal capacity at that level. Now, for the uninitiated, that would be near fatal or fatal, but you're at capacity. Capacity is sort of a semi-legal term, And it doesn't, but you are still thought, even if you're pretty well stinko, you're able to consent to that form. Now, a good attorney will probably argue that in court, but you know, that's what their job is, to do that. Say, well, he really didn't have the ability to consent. Well, then he shouldn't have been driving either, right? We kind of agree with that. Now, then there are what are called exigent circumstances, which means that you don't have to have a search warrant and you don't have to have patient consent. That's if there's been a vehicular homicide. If the patient's unconscious, it's implied, well, if they're unconscious, you're going to start an IV anyway, right? And you're going to treat them and take them to the hospital. So you've already got implied consent to treat, and you can draw blood at that time too. Felony DUI, and that's, the police has to tell you that. If there's a vehicular assault possible, and even if somebody isn't dead, if they've been run into and badly injured, that's vehicular assault. Serious injury resulting in a DUI arrest, and other circumstances to be articulated by the officer. If they ask you to draw blood and it's not going to get in your way of treating injured people, draw the blood for them. They'll sign the thing, put it down the route. Now, you got all the reasons for it. Now, psychiatric disorders. If the patient has significant disorder and they refuse transport, consider police and or mental health professional assistance. Now, we already have had talk by the police as to what their constraints are. They are mostly worried about harming people, about using excessive force, and they get sued for that. And they have not been told. They have been told by their attorneys that their liability protection may or may not be, if they exceed what's considered reasonable force, their liability protection may or may not protect them, and they are at risk for their own economics. A police officer may, at his or her discretion, place the patient on hold or take them into custody. Should the officer elect to not place the person on hold, and that person is, in your opinion, significantly impaired, at risk to themselves or others, contact designated mental health professional. Okay. Explain the situation. The DMHP may then request you transport the patient to either Clark County Emergency Departments or for emergency evaluators, and will instruct law enforcement to place the person in custody. They still may decide not to do that. However, you may use physical and chemical restraint as per protocol. If you make a contact to medical control, that will further improve that. Now, there's a new thing you can do too. If the patient is willing, there's a crisis line that you can call directly and put the patient on with crisis. There's an EMS use only line and then a public line. The EMS only line is 360-397-8198. Explain the situation to the crisis line. They will probably ask you to put the patient on the phone. Sometimes crisis will be able to deal with it right then and there. Right now, we have about 40% of the patients who are calling in indicating that they have suicidal ideation or some issue going on. They contact crisis line only, and crisis line takes care of 40% of those patients, sets up an arrangement with them, and does not have to turn them over to EMS. You don't even hear about them. So you can, if you do hear about this patient, you can put them into contact with Chrysler, and sometimes that'll take care of the problem. And you don't have to fight with them.
Is that the same number you call for the designated mental health professional?
No. The designated mental health professional is listed it's in your orders too. Yeah. Yep. Crisis number only. Okay. Now, near and dear to AMR. Pulsera. Pulsera is a communication app. It's a thing we're trying to institute at Southwest, although this coming week, they'll be in town to talk to Legacy about it also. It was designed initially for STEMI and stroke patients, although there are a couple of places around the country that are using them for general patients, all patients. It's a tool that I think will be, that probably 90% or more of our communication with the hospital will be through an app like Pulsera in the next 5 to 10 years. That the HEAR system will be less and less, because you can send patient identification numbers, you can send, and it's appropriate to send the copy of this a photo of the EKG. You can send information about the stroke patient, about last known well, the LAM score. Everything is included in the Pulsera reports. Take a picture. You can take a picture of the patient's driver's license, a picture of their Medicare card, Medicaid card, any identifying. Send it to the hospital. It goes through the cloud. It is not resident on your machine, on your smart device, and so it is all HIPAA compliant. The problem with it is that it's only on a smartphone application now. It doesn't have an application for Windows-based devices. The problem with, and that's a problem because AMR, which is the largest transporting agency in town, uses, and they're going to be getting notebooks, but it's going to be a Windows-based. The Pulsera is working at trying to make the Windows-based thing work. The hospital has started this, and AMR is carrying iPhones, but little ones, but little iPhones, yeah, and it requires, so unfortunately it requires you to now enter patient data in at least 2 devices, which is, I will grant you, time consuming and not the perfect answer. Now, the people at the hospital who have been pushing Pulsera have been wanting you to use it for everybody, everything. We just had a contact with from the trauma people, and they say, stop using it for trauma. Don't use it for any trauma entries. Just do the standard way, because the Pulsera doesn't have their trauma activation thing set up correctly or set up yet, so that it messes up the trauma system. So any trauma entries, just call in like you always did. Say, this is a full trauma, this is a modified trauma entry, and give them the information over the HEAR system, because the surgeons are already, they're already getting pissy about it. And that's the last thing we need, is more pissy surgeons. So, STEMIs, right now, STEMI is an important one, and you got to take a picture and send us a copy of the EKG, because that's the only way we can call a STEMI. The ED doc has to see the STEMI and says, yeah, that's a STEMI, and they'll call it. Or he says, oh, I don't know about this one. It's a left bundle branch block. I'm going to look it up in the Muse system if we got the patient we get the patient name and identifier, or I'm going to send it to the cardiologist on call and say, what do you think about this one? 75% of the cases that are called STEMI right now come in by Pulsera. 25% of those don't have an EKG attached to it. Well, that's a simple fix. The strokes are doing quite well. Not perfect, but quite well. So concentrate on strokes and STEMIs. The strokes will have the Lamb score. You have to do your own identifier, your unit identifier, and it really, really, really helps to take a picture of a patient identifier. That allows our registration staff to get an actual patient registered before they get there, which saves a whole bunch of time on the front end of getting you through the system. You know, and it's a problem. We hope that, you know, it's something we want to see done. If you have to concentrate on just the STEMI and the stroke right now, do it. And as soon as we get more electronics, you know, if you have time to do it on the other patients, fine. All right, quickie and actually we don't seem to be having any problem with North Country and Camas because you have devices already that work better. So for AMR particularly, sudden unexpected death study, all patients with pre-hospital cardiac arrest, even if you get an ROSC from them, or especially exclusion, traumatic deaths, overdose, draw blood as soon as possible after you get an IV IO, label the tube, name, EMS number, date of service, copy of the hospital face sheet if you've got one, put everything in the baggie, put it in the ambulance cooler, in the refrigerator at headquarters, and we'll take care of it. We're still doing the study. We still, you know, if we get enough patients in there, maybe they'll stop the study. We won't have to worry about it. I don't know if they still bring you pizza or not. Starbucks cards. Oh, that's even better. Yeah. Okay. Not true. Pizzas would be better, huh? We have to tell them to bring you something. But they figure pizzas causes sudden cardiac arrest. Okay, a couple of case reviews. Chest pain, patient stayed sitting in his couch watching TV when he began to have crushing tight chest pain. He denies nausea or vomiting or shortness of breath. Walking out to the ambulance in obvious distress. Alert, oriented to person, place, time, and event. Breathing normally, pale, cool, and sweaty. Vital signs were elevated. Patient placed on a cardiac monitor, reviewed a sinus rhythm, elevation of V1, 2, and 3 with a STEMI activation. IV access established, given nitro and aspirin, transported code 3, en route patient monitored, turned over to the MD, and so here's his, yeah. Well, that's a fairly impressive, now what kind of he has a bundle branch block. What kind of a bundle branch block? He has a right one. It's all elevated, and then he's got an R prime in V1, V2. So, but this is an excellent example of a right bundle branch block that you can perfectly read elevated ST segment in. It's not a problem. So that's an acute MI. If this was a left bundle branch block with that elevation, you'd have to look for all the Scarbosa criteria and diddle around with that one. But this is a nice clean one. So this guy goes, well, there's another repeat. So, went to cath lab, got two drug-eluting stents to the left anterior descending. Post-procedure, his ejection fraction is 40%, which is pretty good. You'd like, he'll get better. Discharged home for cardiac rehab and also to stop smoking, although so that's a good one on that one to pick up. Right bundle branch block with ST segment elevation, and he went, by the way, he went home the next day. We've had two guys who had cardiac arrests, resuscitation, stented, and went home the next day. I mean, you can't buy a bed in the hospital these days, Well, you got to die to get one, Yeah. Upon fire arrival, well, what I'm saying is that, you resuscitate somebody from, generally speaking, from a sudden cardiac arrest. There's usually no significant damage to the myocardium because it was an electrical event. And if you resuscitate them quickly and then fix whatever caused their electrical event, which is usually an occlusion, then there's nothing wrong with their heart. Okay, upon fire arrival, patients lying on the ground with daughter doing CPR. Fire stated patient had radio pulses initially, but then became pulseless and was unresponsive. They started CPR after moving the patient into the kitchen. Daughter stated she had arrived home and assisted her mom into the restroom, and her mom told her she felt like she was going to faint, so she lay down in the grass. I don't know where her restroom was, but my guess is she laid down on the floor and passed out. She was unresponsive, or maybe she had maybe she had a pre-event. She went unresponsive while on the toilet, had agonal type respirations. She then started CPR until fire arrived, patient had also complained of the worst headache ever before becoming unresponsive. When the patient was able, she complained of being cold, nauseated, and a headache on both temples. So we already know we've got some resuscitation here. 58-year-old female lying supine on the kitchen floor with fires performing CPR. Patient's eyes were open and she was blinking but not responsive. Pale, cool, dry. CPR was halted as she was in sinus brady. Patient's vital were obtained, IV was placed. Patient switched from BVM to non-rebreather. Patient carried to the gurney on a backboard. Transported code 3. Given IV Narcan, no change. Second IV placed. Patient was given Zofran for nausea, so she's awake enough to complain of nausea. Patient's lung sounds were assessed, alert, stable during transport. So, EKG, initial EKG shows sinus bradycardia, thought to be post-cardiac arrest. Fluid, blood glucose was 200, blood pressure 170 over 98 after resuscitation. MAP of 122, pulse ox 100%. Got some naloxone, no change. Some ondansetron, 4 lead. Didn't do a 12 lead apparently. Facility activation of cardiac arrest alert. Pulse ox, ETCO2 22 waveform normal. In hospital, as we guessed, the patient had a subarachnoid, acute subarachnoid. She had an aneurysm. So her cardiac arrest was actually a stroke-induced bradycardia, cardiac arrest, unconscious, not breathing normally. She went to IR, had coil embolization of her aneurysm, went home the next day. No, she didn't go home the next day. She's getting outpatient neuro rehab, discharged home with improving activities of daily living. This is not a true cardiac arrest, but appropriately managed. Now, I don't know why, probably didn't have enough time. I'm going to have to surmise not enough time to do a 12 lead. They obviously did a 12 lead when she got in there, but this was a Brady asystolic arrest induced by the sudden application of blood to your brainstem. Doesn't like it. I mean, a great case to get, you know, back home and improving. Code 3, an unconscious patient. Scene is 4 women, including the patient, who states they've been out drinking, but the patient didn't drink much. This is a very unusual case. After they came home, the patient was assisted. She began vomiting, and they assisted, but they said she was always in their presence, never fell, never hit her head, never had anything. She didn't really even have much to drink, they said. A short time later, she became unresponsive and then stopped breathing. They did CPR, then she began to breathe again. No drugs were consumed, only alcohol, and they were drinking at a, quote, safe place. So, on arrival, patient supine on the floor, completely unresponsive to pain, skin is normal color, warm and dry, breathing is shallow but adequate, vitals are normal, moved to the MICU. She then became apneic for approximately 1 minute and had to have ventilation assistance. OPA placed with no gag reflex. Patient RSI with no complications, remained stable throughout. Care and report to ED. So, pulse ox is 98%. Got a little fluid, got some naloxone, no change. Got ETCO2 value is 37, waveform is normal. Blood pressure is good, 151 over 100. Got some atomic sucks, was intubated, got a normal ETCO2 value again of 38. This was after she became apneic for 1 minute. Everything else, all values are good. ETCO2 is 34, bilateral rest sounds, etc., etc. Now, no cause was found whatsoever for this profound loss of consciousness. Bystanders, this appeared to be a cardiac arrest. At least we, as trained medical people, saw her have a 1 minute episode of apnea. All drug tox screen was negative except for blood alcohol, which was 0.09. Now, this is the most profound result of, I mean, some people can't handle much alcohol, but this is pretty hard to believe. I mean, to the point where you can, you know, take an OPA and literally get, you know, have CPR and everything else going. So head CT was negative, labs are all negative, everything was negative. She was ultimately extubated in the ED. They were sent to the ICU because they said, this is really bizarre. She was totally normal 6 hours later. By the way, you burn off 0.2 alcohol. You know, if unless you're real lightweight, you could maybe 0.015. We could burn off every hour. So in 6 hours, we'd normally expect her to burn off 0.09 at 0.015 per hour. So it may be entirely alcohol related, which is, you know, I mean, it's excellent management by field personnel and good care is just sort of astounding. I mean, that's a lightweight to say the least. Okay. This is dispatch on a psychiatric problem. Patient was found lying supine on the ground in the garage of his personal residence with layperson CPR in progress. Per wife, patient handed her a suicide note, put a rope around his neck, and then jumped off an approximately 4-foot-high surface in the garage. Yeah. Bystanders state they found the patient hanging from a rope that was attached to the garage ceiling. Per bystanders, one of them had cut the rope and put him on the ground. Bystanders state they initially felt a radial pulse, no longer could find it, and been instructed to do chest compressions. 4 minutes of layperson CPR performed before EMS got there. He's in his mid-40s with saliva, mucus noted around the mouth, agonal gasping respirations, unresponsive, pupils fixed upward, began chest compressions because he couldn't find a carotid pulse. After approximately 1 minute of EMS CPR, patient found to have an organized rhythm, weak radial pulse. Unconscious, non-purposeful movements of his extremities, C-spine precautions, moved from the ground to the gurney with no incident, continued to remain unresponsive, gasping respirations, airway adjuncts attempted, suction been unsuccessful due to the trismus. Patient's airway was unable to be maintained without RSI, so he was RSI'd, transferred. ET tube remains in place throughout transport, reconfirmed. Thank you for that note, by the way. It's nice to see that. So, initial GCS is 6. Suction, ETCO2 is 34. iGel unsuccessful because they couldn't get it in due to the trismus. 190. My guess is he was probably having an anoxic seizing kind of episode for the trismus. So the treatment of that is to intubate, is to paralyze, intubate, and sedate him, which we did. 2 tries, that's okay. ETCO, because you're trying to protect his C-spine. ETCO2 initially is 47, waveform present, and ETCO2 stayed up a little bit. Got some vecuronium for transport. And he did it remarkably well. Didn't go home the next day, but went home. He came back to normal mentation. He did not have any neck injury, although he had appropriate C-spine control. He woke up, he was ultimately extubated. He seemed to be neurologically functional. He was started on antidepressants, so had some psychiatric intervention at that time. And is in outpatient treatment for his psychiatric issues. It's an excellent case. First of all, the bystanders got appropriate CPR instruction by dispatch. They started that almost immediately. EMS crews did then really good CPR after taking over, and appropriate decision to intubate, protect C-spine, intubate early, get him stabilized, and he did remarkably well. So it's a good save all the way across the board, and hopefully he will survive the psychiatrist. All right. What's on tap for next month? Geriatrics? Ooh. Old people. MPDs. And there will be some additions, some changes in orders.